All right, I think we'll get started. Good afternoon. Welcome to today's webinar entitled Leverage Technology to Automate Data Collection for Outcome Evaluation. Note that this webinar will be recorded and today's participants will receive an email with instructions on how to access the recorded link, which will be saved and posted to the REO website and the RE Health Communities of Practice. At the time, all participants are in listening mode and automatically muted for the presentation portion of the session. There will be an opportunity to ask questions at the end of the presentation, and there are two ways to do so. The first option is to type your question into the chat box on your screen, and the second option is to unmute your line by pressing *7 and asking the question verbally. Thank you, and I'll turn it over to Rita Wilson, Program Manager here at RNAO, to begin.
Good afternoon, everyone, and welcome to our first presentation in our eHealth webinar that is offered during the spring. And our goal really is to highlight some of the exciting work that we have been doing in eHealth. This presentation, as Tanya has already stated, is entitled Leveraging Technology to Automate Data Collection for Outcome Evaluation. I have the pleasure to be co-presenting with Jane Sparks, Deborah Johnston, Mel Phelps, Von Scher, and Bob Chapman. I will ask each of them to introduce themselves just prior to presenting. The presentation today is results of a peer leader initiative that was funded by Canada Health Infoway. And this initiative has two key organizational capacity to implement best practices to prevent and manage pressure injuries and diabetes-related foot ulcers, and to leverage technology to promote best practices and implement standardized processes that automate data extraction for outcome evaluation and quality improvement. And I'll turn it over to Jane, who will tell you Canada Infoway's involvement in the project. Mute, Jane.
Can you hear me okay?
Yes.
Perfect. So my name is Jane Sparks, and I'm the nurse leader on the Clinical and Change Leadership team at Infoway. Infoway helps to improve the health of Canadians by working with partners such as the RNAO to accelerate the development, adoption, and the effective use of digital health across the country. Infoway is an independent, not-for-profit organization funded by the federal government. Infoway's clinical peer networks promote the active engagement of health care professionals in the implementation of digital health solutions in their respective communities. The network brings together natural leaders, physicians, nurses, and pharmacists, and other healthcare professionals to share best practices and build new knowledge, draw on the experience of peer leaders, and facilitate education, identify common and unique enablers and barriers to clinical transformation using digital health. To date, over 960 physicians, nurses, pharmacists, and other peer leaders have engaged almost 39,000 of their colleagues across the country. Peer programs have primarily focused on enhancing the use of electronic medical records, electronic health records, and drug information systems. Current active provincial, territorial, peer-to-peer clinical networks are found in BC, Alberta, Saskatchewan, Ontario, and the Northwest Territories. These peer network projects are focusing on advanced clinical e-functions and patient services, a few of which we will be hearing about shortly. Additionally, there are ongoing faculty peer leader network projects across the country. These networks are focusing on integrating informatics competencies into the curriculum of the schools of nursing, medicine, and pharmacy. More information about these other projects can be found on the Infoway website.
So, the Leader Network was established as part of Infoway's clinician peer network in January of 2016 to achieve the project objectives that I spoke about earlier. There are 6 nurse peer leaders that are part of this network, and they are employed in St. Joseph's Healthcare Hamilton, Bay Healthcare, Blue Water Health, and Chartwell Retirement Residences. And so as you can see, we have a really good representation from a variety of sectors. The role of the nurse peer leaders is to provide technical expertise, leadership, and to supplementation within each of their respective organizations, and a standardized implementation approach that promotes evidence-based wound management in the day-to-day work processes of frontline staff. Identify the practice and policy changes required to support the implementation, and to use the data extracted from the system for outcome evaluation and ongoing quality improvement. These nurse peer leaders have to do. They all had to embed ICNP-encoded nursing order sets within their electronic health information systems that are derived from the following best practice guidelines. They had to implement the first guideline that's listed here, entitled Strategies to Support Management in Chronic Conditions, Collaborative. And then they had the choice of either implementing assessment and management of foot ulcers in people with diabetes, or implement assessment and management of pressure injuries for the interprofessional team. At the bottom of the slide, I've got here a subset of our pressure injuries nursing order sets. This, as you can see, contains very clear and concise intervention statements that the clinician at the point of care would be able to in order to be compliant with the recommendations that are published in our guidelines. And at the end of each of these intervention statements, you'll notice that there's an 8-digit numerical code. This is what we call the ICNP code. ICNP stands for the International Classification for Nursing Practice, and it's what we call a standardized terminology language that was developed by ICN, the International Council of Nurses, to describe the work that nurses do. These ICNP codes used and why are they so important to us as nurses. The next slide will provide you with some further information. So here I've got an example of the nursing order set. As we look at the intervention statement towards the end of this nursing order set, that's assess pressure injury using a validated assessment tool, and we see the ICNP code 1040847. And you can see I've got a screenshot of how this particular intervention statement was built into one of the hospital information systems that was used as part of the project. And at the top, you've got pressure injury, which tells us that this is the pressure injury assessment screen. And all of the fields that you can see on this particular screenshot will be taken from the particular wound assessment tool that was used in this organization. The ICNP code 10040847, as you can see, is not visible because it was built into the back end of the system. And on the next screen, I'm showing you a bit more information about how the ICNP functions. So imagine, for example, the clinician is at the point of care and they're completing their pressure injury assessments. And as they're filling in the information in each of these distinct fields, in the back end, the ICNP codes, which are attached to each of these elements, are capturing information that we need to monitor to evaluate the outcomes. So, for example, this particular client had a stage 3 pressure injury. The ICNP codes, as you can see in that subset that is highlighted there at the bottom right of the screen, the ICNP code that would be appended to that in the back end would be ICNP.10040847-3. And that's how the system would know that this particular client has a stage 3 pressure injury. So when we want to extract the information, for example, to identify the number of patients that potentially has a stage 2 to 4 pressure injury, we would use that code to be able to extract the information. So what I'm going to do at this point, I'm going to turn it over to each of the participating organizations, the nurse peer leaders from these organizations, share with their experience in implementing the nursing order sets and the ICNP codes in their respective organizations and using the codes to extract the data. And so we're going to begin with Deborah Johnson from Chartwell Retirement Residences.
Good afternoon, everyone. I hope everyone can now hear me. I've unmuted successfully.
We can hear Debbie.
Thank you, Rita. So my name is Deborah Johnson. I'm the Director of Professional Development and Informatics at Chartwell Retirement Residence, and we have 27 long-term care homes across Ontario. And in my role, I'm primarily responsible for policy, procedure, quality, point-click care, as well as doing special projects like the one that we have partnered with RNAO. And I must say, it's been just amazing. We've gotten results far beyond what we had ever envisioned when we were first approached about doing this. So we've been exceptionally excited to be part of this. So it's been great for our nursing staff. We chose 2 locations, 2 of our homes within Ontario to pilot the use of the nursing order sets in. Chartwell London, which is a 95-bed long-term care home in London, Ontario, and the Director of Care at that site is the nurse practice or the nurse peer leader for that particular home. And then we also chose Chartwell Waterford, which is located in Oakville, Ontario. They've got 168 residents. The DOC is also the on-site nurse peer leader, but their skincare coordinator has been very much involved in the project and providing us with a lot of assistance at that particular home. So in Chartwell, we do have 3 nurse peer leaders. I am the corp one, kind of overseeing everything and working with the 2 on-site nurse peer leaders, and that's allowed us to have a lot of dialogue within our small group in terms of looking at how do we roll this out, how do we make sure that we're not adding work for the sake of adding work, but the work that we're adding is of value. So I'll walk through that process as I explain how we did this. Slide. Okay. So we implemented the assessment and management of, no, we didn't. How do we get foot ulcers for people with diabetes? We did pressure injuries at Chartwell, and then also the strategies to support the self-management and chronic conditions. So two that we looked at and what we had first to get our head around was that the chronic condition that we were looking at in terms of self-management was the pressure injury that the residents had. So that's how the 2 of them related within our homes. All of our uses Point Click Care as their electronic database. So we have a corporately scoped database, so that allowed us to build one application for the project and then have both homes using it in the same fashion. We initially went down the road thinking we would build the order sets as a subset of our care plan library. And we kind of started down that road. We realized, and we got some staff involved and got their feedback, we realized that probably was not the best choice to implement that. So we very quickly did a 180 and went back to looking at building the order sets as user-defined assessment in Point Click Care. One of the reasons that we wanted to do that, we felt very strongly that when we were doing them as a subset of our care plan library, that our staff didn't really realize that they were doing best practice and that they were using order sets, and it was just kind of buried in the care plan process. So by building them as a user-defined assessment in Point Click Care, we were able to actually highlight the work that the staff were doing and be very, it was much easier to demonstrate the impact that this was having in our clinical care. So implementation approach of our project steering committee, which is the corporate nurse peer leader. They have the 2 homes nurse peer leaders. We also did have at the beginning of our project another corporate nurse peer leader, and she left partway through. So that was a bit of a hiccup we had to overcome. But again, by getting more people involved, we were able to lessen the impact that had because we literally just picked up and carried on. We had the skincare leads from each home come, and we actually set aside a couple of days where we pulled all of these people together to really talk about, let's look at the order sets, let's look at how best to build these within PCC, and then most importantly, let's look at what we're currently doing to ensure that we are not in any way duplicating work that we're already done. So this little steering group, we actually sat through a mapping exercise of the order sets and then also looking at what we are currently doing so that we were able to say to the staff, okay, here with this area of physical assessment, we have the physician's physical, we have our initial 24-hour admission assessment in PCC, so that's how we're doing this. So that document became a very useful tool when we were rolling out the education to demonstrate to the staff that we were very thoughtful in the process in how we built this. We didn't just go and build it and let the staff kind of figure it out. We were very thoughtful and very methodical in how we went about it. We also had home teams at London and Waterford and where they were able to identify the champions in their home, and they were the resource people in both homes. They were the skincare coordinators, and they were the resource people that the frontline staff were able to go to get assistance. And at the end of the day, it was always about focusing on our residents and making sure that what we're doing around pressure injuries and skincare is making our residents' lives better. Next slide. So the key indicators as set out in the project, so we did have pressure injury assessment with the new admissions, pressure reduction management, pressure injury incidents, but we also very closely watched our CIHI indicators to make sure that we, to see if we were making progress. These indicators, with Chartwell, we use the analytics module within Chartwell, and by using that module, we were able to actually see immediate results from the through the CIHI indicators. The other thing I wanted to do just before I get into preliminary findings, within user-defined assessment, we also used many of Point Care's new enhancements around building assessments. So when we built the assessment, if a staff member ticked off yes that they had done the admissions or a complete physical assessment, we used the features to auto-populate the ICNP code, which was the section at the bottom of the assessment. And that way we are able to very quickly run a report of our nursing order sets for pressure injuries, and you're able to then extract our data into a report from PCC. And of course, with PCC, you have limited ability to extract data into any other source. So it is a manual entry of data into the Excel document for submission to Enquire. However, using the features of the PCC and building that UDA, it enabled for quick reporting of just we're running the report and just copying the numbers into the Excel workbook. So it worked out very well for us. We were a little hesitant at first because we don't have the ability in PCC to export or create custom reports. However, using the features, the newer features of the UDAs was helpful. So from our so then from our analytics, we were able to very quickly watch how our homes were doing. And this indicator, the first one that's displayed here, is the new pressure ulcer. And again, the indicator is ulcer. They haven't turned the terminology to injury, so I have to stay true to what the actual indicator is. What we did see initially was a slight increase in our numbers around the new pressure injury, but when you go to the literature, you quite often see that you get an enhancement of numbers when you first start focusing on or re-educate or draw people's attention to something. But then when we go to the next slide, which is a worsened stage 2 to 4 pressure ulcer, you can see at both London and at Waterford that the numbers have really come down very quickly. So, for example, at Chartwell London in November, December, we went from 3.9 to 4.8. But then by March, our worsened stage 2 to 4 pressure ulcer indicator is down to 1.23. And the only thing that we have changed at these two homes around skincare is the introduction of the nursing order sets in the homes. And a similar decrease at Chartwell Waterford, where they did go up in that October to December time period, where we're really heightening everyone's awareness. We're re-educating on pressure injuries and focusing on the order set. So it's to be expected that you're going to see some increase in the numbers. But if you look from December down to March, they've gone from 1.97 down to 0.69% for worsened stage 2 to 4 pressure ulcers. So we are extremely excited about these results that we're seeing at Chartwell in these two homes. And the next slide. So some of our lessons learned, and we do sit back and reflect on this as we've been going through the project, because we're thinking about how do we take this now to the next step. But in terms of an implementation strategy, I can't stress enough the importance of taking the time to really plan and think through your adoption and implementation. Initially, we were gung-ho. We knew that the right way was to go into that care plan library. And once we got working through that and working through the process that the nurses would have to go follow through on and how we would then report, when we really process mapped it out to get to that end report of being able to report on it, really quick realized that that care plan library was not the right approach. We did the 360, we went back and restructured it as that user-defined assessment. When we were implementing, we have a training database with PCC, and we actually built everything in that training database as well. We wanted our nurses to not just see the order set, we wanted them to bring with them a resident chart, actually work through that order set in the training environment so that they had that ability to ask questions of the trainer, complete the order set, and then sign it and lock it so that they're going right from start to finish. We needed that to be in an environment that was not going to skew or alter our live environment, so that when we got to the point of extracting data, we were really confident that our data was accurate because they had this hands-on training. Stakeholder engagement, we talk to our RD, our physicians, we talk to our physiotherapist, our occupational therapist. The more people we could talk to, resident council, family council, to let everyone know what we're doing so that they were aware, very important, and then celebrating successes. We also focused heavily on client outcomes. We were very skeptical. We kept saying to Rita, do you really realize who our residents are these days? We weren't sure about how this self-management was going to work. I've realized huge successes. Little steps with your residents reap huge rewards in terms of their quality of life and their engagement, and we've had some amazing success stories at both homes by using the little booklet that we developed to help get residents more engaged in management and healing of their pressure injuries. And also, don't underestimate the impact of implementing best practice guidelines will have on your frontline staff, especially your registered staff. When they know that the assessments that they're completing in point-click care are based on evidence and best practice, we're finding that they want to do them. One of our nurses has actually said, this is like my best friend because I know I go from the beginning to the end, I know I've got everything done. And so how we used our data to improve practice. Well, we thought we were doing a good job related to skin management. However, this project has really clearly demonstrated to us that there's always room for improvement. There's always ways to get better. We use our data through our analytics. We did to help look at whether we need to do a quality improvement plan on this particular area in these two homes. But most importantly, we have demonstrated that using the order set is a way to actually move that publicly reported indicator on worsened stage 2 to 4 pressure injuries in long-term care. And we continue to really focus on getting these order sets done. Okay, I'll take questions at the end.
Is there need to unmute your phone, please? Yes.
Hello, everybody. So sorry about that. My name is Sarah von Schober from Bayshore Healthcare. I'm here to talk to you about my role as an NPL with my peers here, and a little bit about Bayshore. Bayshore, we're a whole healthcare company, and we have many divisions under Bayshore. We also have therapy and rehab, specialty RX, which is a strong component of pharmacists, and dialysis units. A little of our home, if you go, I'm going to control the slide, so sorry about that. The demographics for Bayshore. We are across Canada. We have about 11,000 staff members, And within home health care, we have 60 ages and other demographics, as you see here, from 40 across Canada. And we service around 200 Canadians per year. The project, what we did was we implemented two of the best practice guidelines, and the first was the assessment and management of foot ulcers in people with diabetes. And the second was how do we support these people with diabetes and foot ulcers, and we implemented the best practice guidelines with strategies to support self-management in chronic conditions along the other sites. How this? With first DFU or diabetic foot ulcer best practice guidelines, we did deploy this within our Procura, or our electronic health record, which is our primary record, Procura, within our home health divisions across Ontario. And we redesigned our wound and diabetes documentation, including the ICMP as well, and are able to get data, which I'll talk to later in the slides. For best practice guidelines for self-management, we had the opportunity to take a little bit of an innovative approach, and we co-designed an app with clients and clinicians to deploy the best practice guideline within the technology of an Android app, and clients were allowed to use this within a health coaching self-management program that we've deployed. And the pilot site for this was, as you see there, Simcoe region, where we service there about 2,500 active clients, but we implemented in our wound clinics with Barrie and Aurelia there, with targeting the diabetic wound population. This slide, as an NPL, we are sharing, our implementation approach, how we all see our role as an NPL, and lead to how we deployed this project throughout. It's been about a year, and so through the project, whether it was redesign of the wound documentation within our Procura system or in development of the self-management program, we engaged many of our frontline clinicians or many levels within our organization. An example, yes, you always engage the frontline clinicians, whether it's in the design of the documentation through your acceptance testing before deployment. And so very key in our ongoing deployment and to now, and whether you're evaluating the project, and we are, how is engaging the branch super users, which will be always part of any sustainability model of a project. Our project, like most of the other sites, are engaging your project sponsors and the project steering committee, very key to establish, because of the fact that if there are any risks or barriers, you would go to them and present mitigation plan, and whether you have support, budgetary, et cetera, or any in terms of additional support. Very closely with the project team, and that was a wound clinician at Bayshore who helped to redesign our documentation and implement the app, as well as our self-management and BPSO lead. This was the core team with our clinical informatics team to redesign, implement within our systems. I think working along with the peers here that you are hearing from, it was very good to share. We continue to meet weekly to share experiences and how to support one another. So leaders that we've selected for the best practice guidelines and the nursing order sets, and along with that, the data dictionaries. I'm just highlighting a few here that I've picked out, but there are many more indicators that I couldn't fit all into one slide. But these are some of the key indicators that we're choosing it to ongoingly measure for our diabetic and wound program, and as well as our self-management program that we are, we've implemented in Barrie. So the first one, we're trying to measure ongoing the percentage of diabetic clients who receive basic food education, and we have done this, or we do this, by CNP codes that we've embedded in the system, and we can pull out the data, extract reports, and submit to Enquire to realize for quality improvements or just success rate to how we're doing within day-to-day practice to support our frontline clinicians. So I highlight a few key indicators to share with the group, and then the slide that I'm sharing with you is some preliminary findings, very high level in what we are seeing. Yes, very much of the clinical process or nursing process is supporting that through the ICMP codes that we are providing the education as needed and document this within our care planning so we can extract the data as mentioned. We also are seeing that our frontline staff are continuing to document wound measurements, to be specific, around the whole management of a diabetic wound client. So that's also very interesting, and we can see the adoption rates increasing. Very sharing my experience around the self-management pilot in the app. The clinicians are also very supportive of the app and supporting clients in the self-management, and we have the indicators that we are pulling raw data for that and measuring to see how we are doing and progressing with evaluating the app. So, slide. Continuing with that previous early findings, our lessons learned and overall to the project that as an NPL, it's very important that I see that we apply the project management framework that we've all applied through this project. And that early as that implementation approach that I shared with you is defining your communication plan and engaging, as that was shared earlier, engaging your stakeholders very early and throughout the project, all throughout your lessons learned evaluation. Working very closely with clinical informatics and decision support to, as example, review the reporting indicators, ensure that the data that you're collecting is, appropriate in terms of the data that you want to measure. Involving clients and clinicians as applicable prior to implementation, I mentioned that we involve them through UAT or through the co-design of our app, and really that was key because you're learning before you implement and gain their feedback, and you're able to make the adjustments, whether it's through documentation, and you can changes before you go live. What I'm learning now, and it's the lessons learned, is that we need to, pay attention to define the process, integrate the analysis of data or that quality improvement for clinicians or within the, our project with the with our wound clinician here at Bayshore or BPSO lead. We are seeing the data now, and now what are we doing with the data that I think most of us on the call would share. It's great to pull data out, but it's more exciting to now say, what can we do to improve or enhance practice for quality improvement? And see that this has brought value to this project because we're seeing this as early analysis of what we can do to support clients and the care that we're providing as clinicians. Statements as just mentioned, it's just really that through the ICMP and this project and implementing best practice guidelines through measurement and ongoing measurement of the dictionaries that we've implemented, it does support the that we've implemented through the BPGs and through documentation that we've redesigned for our wound and diabetes clients. And we're also highlighting, best practices and as mentioned, identifying areas that could be our quality improvement plan. As part of being a nurse and clinician, we need to always look at opportunities for ongoing clinical education, and we've identified that through this implementation and project where the nurses have identified that, for example, through documentation, they understand some of the questions, so they'd like to receive more education on diabetes. So we've that part of our quality improvement plan to deploy focused diabetes education with diabetes clinical practice leader. So Millie now, and again at the end of the call, I think we all will have opportunity for questions and answer. Lily.
Millie, just unmute your line by pressing *7.
I have. Okay. Hi. Can you hear?
Yes.
Good. Hi, I'm Emily Helps, and I'm a registered nurse at Blue Water Health, and I work with the professional practice team, and my role here is with nursing and clinical informatics. So a bit about us. Blue Water Health is a 326-bed acute care community hospital in Ontario. We're located in the Erie-St. Local Health Integrated Network. We have 2 sites, Water Health in Sarnia, and then we have Charlotte, our Englehart Hospital in Petrolia. We have staff, physicians, and volunteers that basically number close to 2,500 people, and we are one of the largest employers of Lambton County. Blue Health's philosophy of care is patient and family-centered care, and we also here at Blue Water achieved full accreditation with exemplary status in July of 2015. Our implementation of our project, Blue Water Health embedded the nursing order sets associated with BPGs. Meditech documentation says that is 5.67 magic. So it identified during our accreditation that our documentation actually needed some revisions, so this really came at an opportune time for us. We decided we were going to do the assessment and management of pressure injuries for the professional team, as well as the risk assessment and prevention for pressure injuries. And we were already doing best practice reporting on the Enquire for the management of our pressure injuries, but we have now taken full scope of that and the 2 best practice nurse order sets. As everyone else, we have done the strategies of support management in chronic conditions related to the pressure injuries. Now, for us, the self-management has been a bit of a challenge, but we can talk about that a little bit later. So our approach used the professional practice team, which of the educators within professional practice, and we brought together a wound care team / super users, if we want to refer to them as that. We continued, we did a gap analysis using the RNAO format, which kind of brought to the forefront where we were missing data that we needed to start capturing. And we updated our documentation using these nurse order sets. Also, very importantly, we feel used the phase-in roll-out approach. So we didn't go big bang. We did a couple small units to start with and see how it worked. And then actually we are now live with it across both hospitals. The implementation approach, I think we stole this from Zara. And just want to talk about it a little bit. The project steering committee for us was our executive team. And our project team basically was Dan from professional practice was our clinical lead, and myself. And project sponsors was definitely our chief nursing executive. She supported this project totally from the start. And our NPL network, of course, was the whole group. I mean, right from the support we've received from RNAO, Rita and Tanya, and then meeting almost weekly with the other NPLs. Super users were our wound care team, and then our frontline clinicians obviously were the end users that ended up using our newly created documentation screens. Key indicators basically come straight from the best practice guideline and collection of data through pressure injury risk assessment. So followed new admissions that were at risk for a pressure injury using the Braden scoring tool. And then we, again, so on all new admissions, that was done. And as a need basis, we do pressure injury risk assessments depending on the location of the patients. It could be done on a daily assessment or it could be done weekly, again, depending on the location in our acute care facility. So patients in surgery might have it done every other day, whereas patients in continuing care might have it done daily. So those directions are set to unit. Also, are monitoring our injury prevention and management screen that we was newly created for us, and we pull data, our support services, our techniques, those kinds of things. Our healthcare-associated pressure injuries are also collected, where we look at who actually develop an injury after admission and pressure injury incidents in a risk assessment. The key indicators for the assessment and management of the stage 1 to 4 pressure injury, again, we're assessing anyone that has an injury on admission. We're looking at the reduction management. Again, some of these overlap with each other with the documentation screens that we've built. Our injury incidents. We're also trying to collect data on the pressure injury healing and any healed injuries. So when we built our screen for the actual documentation of the wound, we asked staff to do a baseline measurement of the wound, and that actually is so when they put it in the first time, then it doesn't get changed. And then with every injury dressing change or injury assessment, new measurements are documented. And then we can actually look to see if there's a healing process going on the surface area of the wound. So that has been built in. That's totally new for us. We were not doing that before. The pressure injury prevalence on admission and then pressure injury point prevalence are the last two indicators that we're looking at. And look at our preliminary findings. And so we're looking at one particular unit here. We're looking at the percentage of patients with a pressure injury assessment on new admissions. So we're looking at how many actually had an injury on admission. And then of that, how many below that, we're looking at the pressure reduction management. So we're looking at whether or not, because the patient had an injury, are we implementing the reduction management strategy and the documentation part of that. So of the patients that came in with a pressure injury, pretty much 100% are getting the assessments related to the reduction management. And the next preliminary finding that we extracted was the percentage of healthcare-associated pressure injuries. This number looks high, and I don't think this is where we've kind of done learning and some changing. It's really important that the staff document injury on admission, because if today admit someone and they say there's no injury, and tomorrow they document that there is one, that ends up looking like it becomes a hospital-acquired injury. So we have a lot of investigation on this portion, and we really stress the importance of doing a full skin assessment on admission. So that's one thing that this certainly has taught us as well. On looking at our lessons learned, that it's really important to have that dedicated planning and implementation team, and it certainly was vital to our success. I think both Deb and Zara have indicated that as well. Really is one of the things that are vital. So engaging our subject matter experts, so our clinical people, our informatics people, we were very lucky to have some help with our informatics portion, health tech, and a employer that actually worked with us on some of our build, and it was certainly a advantage to us that we had that. So we worked with them throughout the project, and we understood the implications for the design and how the expertise to build the system. So we need to support the implementation, and develop reports. And this was all very critical to the project. Quality control implementation was key, so it was a phased-in approach. We had talked about doing everyone at the same time, but we're a really strong group of nurses on our one unit that we actually implemented it, and they were key to helping us. They were, a lot of them were on our wound care team, and they just actually went with it. They actually thought that the nurse order sets were important, and they could see it working for them, so they really took it on and were key for us. Nurse order set lead to support various ancillary departments. So we also recognized through the nurse order sets that we had to involve dietary services and physiotherapy, and we had a couple meetings with those. They were also part of our wound care team on an ad hoc basis, basically, and they, with them, we came up with other documentation improvements and would lead to better care and of our patients in the line of pressure injuries. So in our documentation, we used some validated tools. The Bates-Jensen tool is now what we document in for our wound assessments. And also incorporated the subjective global assessment, which is a nutritional screening for our patients. And this certainly helped with dietary and their ability to assess patients who might be lacking in their nutritional content of their meals. So it was a twofold win for them as well. So the IMP codes certainly can simplify our data collection and our reporting. I did find that the ICMP codes had a lot of that covered new interventions, so we had to kind of put suffix on the end of them so that we could identify which ones are which. And the post-implementation auditing process is very important as well. Going on to the next one where we talk about our data-driven quality improvements.
So Millie, in the interest of time,
absolutely.
That presents now because everyone will get a copy of the slide deck so they can review your last slide, okay?
Absolutely.
Thanks,
Thank
Millie.
you. Thank you.
You, please. Starson.
Barb Chapman from St. Joe's Healthcare in Hamilton. I'm a manager in the Clinical Informatics Department here at St. Joe's, and my responsibilities are special and integrating best practice into electronic health systems. So St. Joe's is an academic health science center here in Hamilton, and we are the reading the urinary program, providing nephrology, dialysis, and kidney transplant. So this is an outpatient program, and we see about 1,000 patients per year. 51% of those patients have diabetes, and this is why we one of the reasons why we identified this program is to be ideal for our implementing our nursing order set. We have 150 chronic dialysis patients seen per year, and identified through implementation of best practices with our screening tool, 83 out of 325 diabetic patients have a foot ulcer at any time during the year. Implementation, we adopted the assessment and management of foot ulcers for people with diabetes, as well as the self-management best practice guideline for chronic disease management. And we are using the EPIC ambulatory EMR. And in the build of the work that we did in embedding the nursing order set into the EMR, the EPIC system is very dynamic, and we used care path type of methodology so that we built out logic rules in the system so that it would to go through the assessment, planning, intervention, and evaluation, but only when it was applicable to move into each of those areas, the system would dynamically guide the user to the next step. So, for example, if it was identified that the patient had the risk factor where there was loss of protective sensation, then the user would be prompted to go on and do the monofilament test to assess the protective sensation. So it's a very sophisticated program with the ability to build that logic in. And what we also did in the development was we created some associated tools. So it has smart links, smart phrases, smart notes, where it can pull information that has been gathered during the assessment and the course of care for the patient into specialty notes, so that it provides that summary. If you're doing a consultation or a referral to another clinician, it creates that referral note, and then it auto-faxes it directly to that physician's or the chiropodist or the other CCAC or other healthcare providers that would be involved with the care. So we have these added this functionality and value to in the system. Approach in assigning the ICMP codes was a little different than the other groups because we already have SNOMED CT integrated into our electronic medical record. And the International Classification of Nursing Practice concepts are mapped to the SNOMED codes. So we mapped all of the built to the existing SNOMED codes into the system. And then we were able to then take all of the variables within those concepts and create the groupers. And that was helped us create the or build the extract reports to report on our indicators. So our implementation approach is the same as the rest of the nurse peers. We had a project sponsor, our Director of Nursing Practice here at St. Joe, Cheryl Evans, and our Senior Manager of the Nephrology Patient Program, Garens, were our project sponsors. And our project team approach was we had 3 project teams, and members on the project team would be cross-represented on some of the other teams. So we broke it down into a team that looked at the nursing orders and how we built them out in the EPIC ambulatory EMR. Another group, we looked at self-management, and we brought public affairs into that group so that they could provide us some advice on information, materials, and strategies on engaging their patient population, which was a really valuable strategy that we had. And we had our evaluation team, which included our report analysts, as well as our clinical folks, our clinical subject matter experts in that group. So, our implementation approach. So our informatics application specialist, who is also a registered nurse, she took the nursing order sets and designed how they would be built into the EPIC system. And then once that draft was done, presented it back to our clinical subject matter experts, our primary care nurses, diabetic nurse educator, and wound care nurse practitioner. And so we did some back and forth until we got it right, and they validated that build, and then they conducted the user acceptance testing. Then the same team, along with our principal trainer for our EPIC system and our clinical informatics nurse, we collaborated together to put an education package together for the nurses in the front line, and we delivered the education to that group. Go ahead, Tanya. Okay. So some of the key indicators, we're looking at the number of patients are diabetic that have a foot assessment, those that have a foot ulcer, and then looking at adhesion and evidence of healing and referral to other clinicians for further care. Some of the findings, we're just examining our data now, and what's seen in February is that 100% of our patients that are diabetic do have a foot ulcer when they come in for their clinic visit. And in February, we identified 12 patients that had a foot ulcer, and these were, from here, some of the patients not have follow-up documentation. So we went in and did a chart on it to find out why, and it turns out that these were patients that were dialysis treatment was done on these patients as an inpatient, and we needed to exclude these patients from the group because although it's important they have foot care and good assessment and foot care, but we use paper documentation in the inpatient area, so it was difficult to assess these patients. This is something we'll be looking at in our bigger project as we implement a fully integrated EPIC system in our hospital for December 2017. We saw evidence of healing and also evidence of intervention. So we'll continue following these metrics and implement quality improvement strategies as we go along. So what the rest of the leaders have said is it's so important to have good communication, good planning, project management framework, and one of the things that we found is specific to our site is that we have two information systems. One's our clinical vision system that is integrated with our dialysis machines and our EPIC system. So there is a little bit of fragmentation of information across the two systems, and that has been a bit challenging to work with. We did have some process changes that we continue to work on to improve, and we do see that we have excellent screen rates, but with the two systems, we are digging into that a little bit further to see if we are missing some follow-up referrals and follow-ups because of the inpatient in two separate systems.
So let's take a few questions now, given the time. It's 1:01. has any questions for any of the presenters, you will need to unmute. While doing that, we're going to read one question that came in for Chartwell. It says, how did Chartwell separate the success that was noted from the nursing order sets with the success of targeting self-management through the brochure that was described? I'm curious to know whether they have separate evaluation data on the two. So if you can answer that, please.
We know who we used the self-management booklet and the order set on, because we did use some screening criteria based on MDS outcome scores for who would be appropriate to use the self-management. And if there was any question whether it would be appropriate or not, we always erred on the side of caution and did make attempt to engage the resident in the self-management piece. What we have is more anecdotal evidence and case study evidence that it was working, because we have a long history with the residents where we've had some really good news stories. We have a long history with those residents of trying to heal these pressure injuries. We can also dig down into the QIs around worsened stage 2 to 4 pressure ulcer, and through the analytics we can see, for how many past quarters did the residents where we used self-management, for how many past quarters did they trigger the worsened stage 2 to 4, and then at what point did it stop, and where was that time point in relation to where we introduced the self-management. So we can do that further deep dive into the data. We just haven't quite gone there yet.
Thanks, Deb. In the interest of time, I'm going to ask if there's anybody else who has any questions. If you email us, then we can get the responses and we can correspond with you via email. I'd just like to now draw your attention to the slide which is asking you please to participate in our evaluation. We really would like to hear from you in terms of whether or not you thought this webinar session was informative and what you learned and how you think perhaps it will impact your work going forward. Also, I want to inform you of the upcoming webinar series. So here you've got the dates. And as you can see, we've got some sector-specific webinars targeted next coming weeks. And so we would invite you to please sign up to participate in one of these webinars. And this is where leaders go into more details around the specifics of their integrating the nursing order sets into their respective systems. And but not least, just to let you know that if you require further information on this project or on the nursing order sets, then please email me, rwilson@rnao.ca. Thank you all for taking the time to be with us today, and we hope that you found the session very informative. Bye-bye.